So hopefully that'll work for you.
Hi, Sarah.
Hey, Courtney, how are you?
I'm doing pretty good. How about yourself?
The executive director of the Delaware Diabetes Coalition. And thank you so much for joining us last night if you were with us, and again tonight for day 2. Last evening's sessions were very informative. The evaluations I reviewed today all seem very positive. So we thank Dr. Matt and Dr. Anita again for being with us last night. I do see in the chat about the CEU certificate. So yes, you'll receive 1 certificate after the whole event. And depending on how many hours you were part of the event will determine the CEU number. So I have to wait till it's all over and then I'll email out the certificates. So just a quick recap, if you were with us last night, this is going to be a repeat, but if you were not, the Delaware Diabetes Coalition is a statewide nonprofit organization comprised of a network of healthcare organizations working together to improve the lives of people in Delaware affected by diabetes through awareness, prevention, identification, dissemination of services, and advocacy. We started this event last year. We pivoted because we used to do a partnership with Christiana Care, and they would host an in-person event in Wilmington, and we would do a virtual event in Lewis. And there was no need to do virtual when have an in-person virtual event when everything went virtual. So we pivoted to focus on school nurses because we have a college scholarship for type 1 and type 2 Delaware residents for seniors going into college or students already in college and continuing on through, their senior year. And we have $1,000 every year. The application deadline is April 30th, and we weren't getting applicants. And so we figured we would target the school nurse audience to help get our word out about this scholarship. So in the coming months, I will be sending out a reminder, but if you do have students that are eligible, please convince them to apply. To get your CEs, you have to watch the 120-minute webinar tonight and complete the evaluation by the end of this month. I will send the certificate and you will get your hours, 2.0 hours for tonight, 2.0 hours for last night if you participated, depending. And when you fill out your evaluation, make sure you check which certification that you're looking for so that I can give you the correct certificate. And any speaker and planner disclosures, which there are very few, are on our website if you'd like to look them over. And the learning outcome is the same as last night, but we're going to talk about the physical aspects of youth and diabetes, current diabetes technology, and the mental health aspects of chronic disease to better support and care for children and teens with diabetes in a school setting. And so with that, Nina Fletcher is the president of the Delaware Diabetes Coalition, and she's going to welcome you.
Well, good evening, everyone. Thank you again if you're a repeat customer tonight, and if you're not, welcome. Hopefully this will be a lively and as informative 2 hours as last night was. And we welcome you and thank you again so much for your participation. I want to acknowledge the planning committee Amy Hastings, Courtney, and Sarah and I were part of the, we're on the planning committee, and I'm very happy to say that so far so good. So without further ado, I think Courtney, you're up.
Yeah, well, right before she starts, I'll do an intro, but also a reminder, if you do have questions, make sure you put them in the Q&A box. They'll get lost in the chat, and we certainly don't want to lose anything. So if you do have Q&A throughout either session, make sure you put them in there. And at the end, I'll go through them with the speakers individually. And with that, now I'll introduce Courtney Masterson, is currently employed as a practice transformation specialist with Quality Insights, working on their state contracts team in both Pennsylvania and Delaware. Much of her time is spent working with primary care providers to improve diabetes and hypertension outcomes within their practices. Her background is as a dietitian, specializing in end-stage renal disease. And just this past May, she completed her master's in health administration and has transitioned her career to focusing on prevention and early detection. Along with her professional experience of working with people with diabetes, she also lives it, having had type 1 diabetes for the last 6 years of her life after an adult onset age at 23. Courtney, thanks you so much for being with us tonight.
Absolutely. Thank you for having me.
Of course. And with that, I'll stop the share, and you should, oh, I might have to give you permission. Hang on.
Okay.
Okay, you should be able to go now.
Okay. All right. Can everyone see my screen?
Yes, you're good. I can see it anyway, so hopefully everyone else can.
Okay. So thank you everyone for joining us tonight. My presentation is going to be on the connection between diabetes and mental health. I do work for a company called Quality Insights. And as Sarah said, I am both a dietitian as well as having a master's in health administration. So these are going to be our objectives for my presentation. I'm just going to give you guys a second to read them, and then we will move on. Okay, so I thought I would start my presentation with just a little bit about me. So I am turning 30 in April. So I have had diabetes since I was 23. So I'm actually coming up on my 6th year of having it. I am a registered dietitian by trade. I'm a late onset type 1 diabetic, having actually already been a dietitian when I was diagnosed as a type 1 diabetic. I love to travel and have been to 13 countries. And as you can see, I have a very spoiled dog who loves to sleep in the sunshine. So just a little bit about the company that I work for. So Quality Insights is a nonprofit. We work to pursue better care for patients in all of the states that we're contracted in, which at this point is quite a few, but I primarily am in Delaware with some time in Pennsylvania, and we're striving to work with primarily primary care physicians to have better outcomes for their patients. So I thought that we would just start with a little bit about diabetes in Delaware. So between 2000 and 2017, diabetes prevalence in Delaware did increase by 82% among the adult population. In pediatric cases, we have seen an increase in both type 1 and type 2, with type 1 increasing by about 1.4% and type 2 about 7.1% annually between 2002 and 2012. So these numbers show that there's a lot more children and young adults living with both type 1 and type 2 diabetes. So what is mental health? Mental health includes our emotional, our psychological, and social well-being. It affects how we think, feel, and act, and it also helps determine how we handle stress, relate to others, and make healthy choices. So while all of that may sound like a lot of garble from the CDC, more than half of the US population will be diagnosed with a mental health disorder or a full mental illness in their lifetime. And as should be noted, many of these things will also affect a diabetic's ability to care for their own disease state. So what are some things that can affect our mental health? In the general population, things such as loss, housing stability, financial stability, major changes in our life are all things that can affect our mental health, as well as has been going on for the last 2 years, a global pandemic. All of these are really heavily going to affect anyone that is going through it, their ability to cope and deal, and also where they are in their quote unquote headspace. In addition to all of those things, though, the general population do live with, there is also an added component for diabetics, whether they're type 1 or type 2, which is a lack of understanding from a lot of the population. From my understanding, most of the people who are joining us tonight are, in the healthcare field. So you guys have a little more understanding than the general population. But I want you to acknowledge that you're also not immune to sometimes contributing to what diabetics go through, the stigma that we can experience. So if you read the top quote there, aren't you going to go to the bathroom? You can't just do that here. So this was said to me when I was out with a friend for her mom, for her birthday with her and her mom and her sister. And her mom said this to me when I went to go do my insulin at the table. She expected me to leave the restaurant to go to the bathroom to do my injection. And her mom was a nurse. She thought that it was inappropriate that I was going to use my syringes at the table. And unfortunately for me, this was only about 6 months into my diagnosis. So it was really stigmatizing to me. Like I felt like I was ashamed, like I had done something wrong. Luckily, my friend did back me up. She did say to her mom, how unsanitary that is, how it was wrong to shame me for doing what kept me alive. But it is important to realize that sometimes we don't always acknowledge that stigma that exists. We don't always acknowledge the burden that this disease puts on people who are living with it. As you can see, I've also been told by a random stranger that I should be ashamed of myself while doing my insulin. And I also, for the last quote, I was given a regular soda while out to dinner with friends. And when I brought it up to the waitress that it was a regular soda, this was actually said to me by a random stranger in another booth. The waitress, had no problem with it. She was going to bring me a diet soda, but another person told me it's not going to kill me. And, obviously, had I not known, it is something that could have landed me in the hospital. So there is this kind of lack of understanding in the general population, especially when someone looks like myself or looks, young, like a lot of your students are or will be, that they look young, they look healthy. And so people don't understand that this disease state, you don't have to look like you're sick all the time. You can be coping with it. You can be dealing with it and looking healthy. I have been ziplining in Costa Rica, but that doesn't stop the fact that my disease state affects me every day. So just some statistics about diabetes and mental illness. People with diabetes are 2 to 3 times more likely to develop depression, while only half of those people will get proper treatment for that depression. And they are 20% more likely to experience anxiety at some point in their life. A lot of times this is surrounding their disease state, whether it's the reality of their disease state, coping with their disease state, the burden of their disease state. It's all things that can contribute to someone having increased risk for depression and anxiety. So as we discussed, there are a lot of things that can cause mental health issues. There's also a lot of things that can cause mental illness, whether they're external or internal factors. You can see here on this slide that things like genetics and brain chemistry can have a big effect on mental illness, as well as physical health and poor nutrition, which are also both two things that affect a person's diabetes and how well they're handling their diabetes. But as this is a discussion about mental health and diabetes, I want to concentrate on that last symbol that you see there, which is stress. So just the act of living with diabetes can cause a lot of psychological effects for the person who's dealing with it. It is a 24/7 disease. It requires constant monitoring and intense drug regimens. Every visit with a practitioner, not just your endocrinologist, your disease state is brought up. Perfect example, on Monday, I went to a new dentist. I've had the same dentist my entire life, and unfortunately he retired. So I had to find a new dentist. When I told them that I was a type 1 diabetic, the first thing they said to me was, you're at higher risk for gum disease, right? Yes, I know. I'm at a higher risk for everything, I've been told. And while it's important for the practitioners to talk to you about that, it can be very draining, knowing that every time you go to a different doctor, whether it's my dentist, whether it's my eye doctor, where I have to have a special eye exam, wherever I go, it's always something that's brought up, and it can make it feel like it's inescapable. And unfortunately, some providers will use scare tactics to try and motivate compliance in patients. which oftentimes only adds to stress level. When I was in dialysis for 5 years. Most patients who end up in dialysis are not there because they were compliant with their hypertension or their diabetes. They're usually there because they were quote unquote non-adherent or non-compliant patients. And using scare tactics typically isn't going to have a good effect, whether it's on children, whether it's on adults. Being forced into things and not taking the time to educate the patient about why it's important and why they need to follow the regimen that they've been set often just creates more stress and more pushback from that patient in my experience. Personally, I am not someone who enjoys being told what to do. So when providers take the time to talk to me about why I need to do this, what the reasoning is, I'm much more motivated to do it because then I'm involved in my own care. And especially as you work with, young adults or teenagers, that can be very important, making sure that they completely understand why this needs to be done without using scare tactics on them. So just to give you guys a little bit of an idea, I'm sure a lot of you, being healthcare professionals are at least somewhat familiar with what the regimen is for type 1 diabetics. Obviously, it's going to vary a little bit for type 1 and type 2. But this is my daily regimen for my diabetes. So in the morning, I'm going to wake up, I'm going to check my blood sugar. I do have a continuous glucose monitor, but sometimes I still check my sugar by pricking my finger just to make sure that that continuous glucose monitor is accurate. Depending on where my blood sugar is in the morning, sometimes I experience dawn phenomenon. I might have to take some fast-acting insulin and then wait for a half hour to an hour before I can have breakfast. Or if I'm in a normal range, then I'm going to eat breakfast immediately. At least a couple times a week, it's not every day, but at least a couple times a week, I am going to underestimate a meal, and I'm going to, at some point in the day, whether it's after breakfast, after lunch, or after dinner, at some point in the day, or some point in the week, at least a couple times a week, I'm going to have to do another injection for a meal that I under bolused for. Before lunch, I'm going to check my blood sugar again. I'm going to take my third injection of insulin at that time to cover my lunch. In the afternoon, I will typically go for a walk with my dog. So that dog, that spoiled pup that we saw in the beginning. And at that time, I need to carry, unless I'm with a family member or with a friend, I do need to carry an alert card that explains that I am a type 1 diabetic. And I also carry sugary snacks just in case I experience a low blood sugar. In the past couple months, I was fortunate that when I switched to Quality Insights, my new insurance covers Dexcom. My previous company, when I worked in dialysis, I was not that fortunate and I had to use a Libre, which while Libre is a great system, it does not have predictive alerts. Unfortunately, there have been times where because I did not have those predictive alerts, I would be 2 miles away from my house and I would scan and it would tell me that I was 65 and dropping. So what do I do at that point? I can either eat the candy I have and sit down for 30 minutes if I'm 2 miles from my house, hope my blood sugar comes back up. Or there has been a couple times where I had to call my mom, which I am lucky that my parents only live 10 minutes away. She came, picked me and my dog up and drove me back to my house. So, even at almost 30 years old, this disease makes me a little more reliant on my parents than I would like to be. And then finally, I check my sugar for dinner. And I will take both a fast-acting and a long-acting insulin at that time. So we're looking at injection 4 and injection 5 of the day. And this is only if I'm eating my 3 meals a day. So if I want a snack at any time in the day, I'm looking at a 6th one. If I want to go out with friends, and sometimes we're ordering food in waves, because I don't want to plummet myself, I'm going to do multiple injections. And I would say that my top on a really bad, well, bad as in like lots of carbs, day with my friends was about 11 injections. I have just recently started on a new insulin pump. Fingers crossed, I like it. I did not like the ones in the past, but yeah, prior to that, I was doing multiple daily injections. And, sticking a needle into yourself 6 to 11 times a day will have an effect. that effect, honestly, the stress that comes with diabetes, a lot of times is just living with your disease state. As I mentioned, it's a constant. It's something that you can't escape. We don't get off days. And when we have abnormal blood sugars, for example, a high blood sugar, it can cause, not only physical and emotional issues for us, it also has psychological effects, all of which cause further stress for the person who's living with the disease state. And that stress for that individual can then contribute to even higher blood sugars. In the past, I had, a couple days where I had something either mentally or emotionally draining on me. And it has caused really high blood sugars for me, to where at one point when I unfortunately had a really bad conflict with a friend and we couldn't resolve it, and I ended up losing her as a friend. I spent 3 hours on the treadmill that day just trying to run down my blood sugars. And ultimately, I still couldn't get below 200. So, the abnormal blood sugar can cause more stress. Emotional distress will cause more stress. And all of that combines to just increase blood sugar, because your liver is putting out the glucose to try and deal with that stress, but your body can't process the glucose correctly. And obviously, the population that you work with, there's a lot of individual stressors for them. So things like academics, especially during COVID, where they're having to online learn, or they're not getting the time that they need, the in-person that they need with the teacher, that can cause a lot of added stress if they are failing to adapt to, the new learning system, or they're unable to get the help that they need from the teachers. Home stability, so many things can go into that. Bullying, unfortunately, as much as we would like to think it's not a thing, bullying is in every school, and it does run rampant in the young adult, early teens. And it's something that a lot of people have to deal with, especially people who are quote unquote different. Anyone who has a disease state when they're as young as these kids are, they're different. And it's hopeful that that's not held against them, but that really depends on their peers. It depends on the education of their peers. If their peers understand what they're ultimately going through, whether or not they're going to be bullied for that disease state, whether, if they have an insulin pump attached to them, is that something that they're going to be bullied for, and it makes them feel different. Juggling responsibilities, if they're a student athlete, as well as on top of their academic and their home stability, they're also trying to deal with their blood sugars while participating in those sports that, they love very much. If they have a job, that can be another stress that they're trying to deal with on top of their academics. And then body dysmorphia. Being a dietitian, eating disorders, are very common, and unfortunately even more common in young adults who have things attached to them. So again, whether it's a CGM, whether it's an insulin pump, it can have a psychological effect on these young adults who already have a distorted image of their own body. So there's a lot of things there that can contribute to their own stressors as young adults. And obviously some of these things we don't really, unfortunately, ever grow out of. We can always feel different. I myself put myself through a master's degree on top of working a full-time job. So, some of the things never go away, but they can be especially hard for young adults and teenagers. And all of these things can then contribute to that home stability, because it can cause familial stress, especially in children. The stress of coping, like young children, obviously they're too young to take care of their own diabetes. They can't dose their own insulin. Carb counting is probably a little outside their wheelhouse at that point. And the stress of coping with that disease then extends past the individual living with it to your parent, or to the parents. The parents are forced to be hypervigilant with their children and the medications. They can't just go to events like most children can. Personally, as I said, I was diagnosed at 23, so I can't speak to this, but going to a friends, to a friend's birthday party can be a stressful situation because is there diet soda? You know, is your kid going to have the cake? How much frosting is on that piece of cake? How do I carb count that cake? Oh, did they just eat a cookie? I need to carb count that too. And it's just so many complicated decisions that it creates a minefield for these parents and for the children. And unfortunately, sometimes that can actually contribute to the eating disorder that some children will develop because their parents are so focused on what's going into their body, as unfortunately this disease state calls for, that it can then cause an unhealthy relationship with food for the child. And this also can somewhat put a strain on the family if there are other children in the family, and especially depending on, you know, the age ranges of the children, because a lot of time that child that's living with type 1 or type 2 diabetes is going to require a little extra attention than a healthy child. So, you know, it can cause some tension between siblings. It can cause stress for the entire family. I think one of my favorite stories for this, which again, I wasn't diagnosed as a child, but I have been vegetarian and transitioned to pescatarian when I was diagnosed for coming up on 14 years. I was diagnosed 6 years ago with diabetes. And the one time I went over to my parents and my dad was like, Courtney, there's a new chicken place down the street. I was like, okay, like why does that matter? And he's like, well, because chicken doesn't have carbs. He was so proud of himself. He was so proud of himself for knowing that chicken doesn't have carbs. And I looked at him and I was like, Dad, I've been vegetarian for 7 years. And then he remembered that I hadn't eaten chicken for much longer than I had been diabetic. And while I appreciate the care, it causes a stress. If I decide to sleep in sometimes and I don't speak to my mom before noon, she will call me concerned that something happened in the night. And I said, I'm turning 30. So this familial stress really doesn't evaporate as children get older. It just takes a little less responsibility off the parents. And unfortunately, people who are living with both diabetes and mental health issues, whether it's full-blown mental illness or just mental health struggles, are much more likely to experience non-adherence to both medication and self-care. It's really hard when you're struggling with your mental health to find the ability to go out and exercise to bring your blood sugar down. The functional impairment that comes with a mental illness, a much higher risk of complications from a lack of control of their blood sugars, higher healthcare costs, often going with everything listed above that, and then often early mortality. Diabetes already gives you a much shorter lifespan than most people. And when you add in mental illness and the inability to fully care for your own disease state, it just causes many more issues that will more than likely also lower your lifespan. So it's kind of a compounding issue. So I thought that a good example for this would be a personal example. So on Sunday, December 12th of last year, I was at the dog park with my dog. That's why I showed you guys a picture of him. Like I was almost every Sunday morning. It was our routine. We'd get up, I'd have some breakfast, we'd go to the dog park, hang out with the regulars. We had been going to the same dog park for 2 years. So we got there around 10 a.m. So we're looking at the top graph there. So right now, just kind of ignore the bottom graph and just look at the top graph. So we got there around 10 a.m. Around 10:20 in the morning, my dog got into a fight with another dog. This is a dog that he has played with for 1.5 years. We have no idea what caused it, but at that time, I saw my dog's muzzle in that other dog's mouth, and by the time we got them separated, he had face lacerations. And I, unfortunately, in the process of trying to separate them, had also been bit by a third dog. Just trying to get out of there, trying to keep my dog safe, trying to keep myself safe. I did not realize the extent of my bite. When I got home and took off my my pants is when I saw that I had a very deep bite. At that time, unfortunately, because there had been 7 other dogs in the dog park, I didn't know who bit me. I had known 6 of the 7 dogs at that dog park. We'd known each other for 2 years. But because I didn't know the one dog and I didn't know who bit me, my primary care doctor told me that I needed to go to the ER to get rabies shots. So you can see in the middle of the graph, that is noon. So noon was about when I got to the ER. About 3:30, 4 o'clock is when I was discharged, got home, got my dog from my parents, and got back to my house. And that is when the emotions of everything that happened that day set in. So a lot of emotional turmoil, a lot of stress of, am I going to get rabies? Is my dog okay? Do I need to take him to the vet? Because like nothing for him, like he had one deep cut, but nothing much besides that. So I thought I would just keep an eye on it for him. But so you can see around 3 o'clock that my blood sugar starts to go up. So anything in orange is a blood sugar higher than 180. And over the course of the night, the stress and the trauma of what had happened that day to both of us started to develop for me. It started to set in. And unfortunately, the bite was so deep that every time I would roll onto it in my sleep, I would wake up in searing pain. So, I'm having physical distress, I'm having emotional distress, I'm having mental distress. And as you can see, after 9 o'clock on the 12th, and if you now look down to the bottom graph, it's all orange for almost 12 hours straight. Every time that I woke up, I was afraid that something had happened to my dog, that he had some kind of internal injury that I didn't know about. I was in physical pain, and I want to say that I slept maybe about 3 hours that night. So all of these things were affecting my mental health and my ability to deal with my disease state. So I spent almost exclusively 12 hours above my goal of 180. And as you can see, from 9 a.m. to the remainder of December 13th, I spent a lot of time on a roller coaster. So that was me trying to figure out how to bring my blood sugar down when I could barely exercise because I was in so much physical pain. I on a regular day, I will typically spend anywhere between 75 to 80% of time in range between 75 to 80, from 70 to 180. So I'll spend about 75 to 80% of my day within that range. On this day, I maxed out at 37% in range. So not a good day. For a comparison, this is a regular day for me. You can see there's a little bit of orange. There's a little bit of kind of skirting the bottom of that of 70, which is, the lowest you want to be. But, it's usually right after meals. I have a little bit of high, which is not uncommon. Obviously, your blood sugar is going to go up after you have meals. But this is a normal day. So when you compare it, to that day, to that Monday, December 13th, you can see the stark difference there. So, there's only so many things that unfortunately anyone can do for their mental health, but encouraging healthy coping mechanisms is something that you guys can do, as well as working with the parents and the student themselves. Exercise is a great way to bring blood sugars down, not only by relieving stress, but also just the uptake of insulin from the exercise itself. Meditation personally does not work for me. I'm not good at shutting my brain off, but it can be great for other people, as well as yoga, taking some relaxing bubble baths or some relaxing walks. Personally, I'm a reader. I love to sit down at night with my cup of tea in my library and just read my book. And it really, I notice that the nights that I don't make time for myself, the next day I tend to have worse blood sugars than the days where I do give myself some time to take care of myself mentally, and also, doing a little bit of the physical with my walks. So what can you guys do as, nursing practitioners and dietitians, especially to children and young adults living with these disease states? Number one, acknowledge the burden. It is a very burdensome disease state that we live with on a regular basis, on a daily basis. And we constantly just wish for a day off. But unfortunately, if we take a day off, it's usually going to land us in the hospital. So you want to acknowledge that burden, the fact that those students are living with something that is constantly on their mind, something they can't get away from, and just acknowledging. And it means a lot when people acknowledge that everything that you're going through. One of a friend of mine is currently pregnant with her first baby, and she was diagnosed with gestational diabetes. And she texted me and she's like, I don't know how you deal with this. It's been 4 days and I'm losing my mind. You want to offer support where you can. Obviously, we want to keep it professional, but offering support, whether it be, talking to the students of, the peers of that student, or making sure that the teacher understands the disease state, any way that you think is appropriate and professional to offer support, we want to try and do that, and to really encourage those healthy coping mechanisms, because that is the best way for a student, for anyone living with diabetes, to take care of themselves and to best handle their mental health so that they can handle everything else that comes with their disease state. But there's definitely a lot of facets to this disease, but really the acknowledgement and support of people in our lives is a huge factor to us, that we have other people helping us, because it's really hard to do on our own. These are my citations, and definitely at this point, so I am a little bit early. I apologize for that. I am a fast talker, but I will definitely welcome any questions.
Awesome. Thank you so much, Courtney. That slide comparison of, the day your dog was bit, that was a really impressive slide, just to see how that, how it all relates, how it all can be affected by one instance.
Yeah, well, so honestly, as another example, which I didn't get to capture because I was making these slides while it was happening, but like a lot of people right now, about 3 weeks ago, I came down with COVID.
Oh gosh.
Yeah.
How did that affect your blood sugars?
So my blood sugars were actually not too bad, but my biggest problem was, so my symptoms were very mild. I had the brain fog, which I had kind of thought was overplayed, not remotely. Trying to make these slides with COVID brain fog was a little complicated. But so my two major symptoms on top of the brain fog was fatigue and congestion. So I hadn't lost my smell, I hadn't lost my taste, but as we all know, when you have a cold, your want to eat is kind of lower. So between the exhaustion and the congestion, on some days I couldn't find the energy to motivate myself to eat. And so being type 1 diabetic, I was also checking ketones, and I was actually making ketones because of how little I was eating. So I actually, on one of the days where I had energy, I spent about 3 hours just making food so that I would have easy meals for the rest of the week, because I was told that if I started developing any more ketones, I was going to have to go to the ER because of that. So,
and not because of COVID. Yeah.
Not because of COVID, not because my blood sugars are high, just because I can't find the energy to eat.
Yeah. Oh my gosh.
Which is, just kind of an added thing to this disease state, because, if most people, if they don't eat, it's just like, oh, well, it's not great for you, but it was very annoying.
Yeah.
So especially I was trying to not order takeout.
Well, Nina has a question.
Well, yeah, I actually, Courtney, that slide was amazing. And I would like to say to the ladies, nurses that are on the call, or that if your student has a CGM, that is probably a really helpful tool, resource for you to help to a teachable moment, if you will, to help them understand what percentage of the time they're in range and what percentage of their time that they're not. That was beautiful, and I would encourage the nurses to try to find a way to do that. I'm also curious we have 66 people on here. I'm curious if the folks that are on have any idea how many of their students are on CGMs, because that'll be Tina's next, and she's going to talk about technology. So it would be nice for her to have a good idea about, if she's preaching to the choir or if she's really got a viable audience. Not that we don't always have room to learn more, but is there any way for us to figure that out, Sarah? How many?
Yeah, people can put in the chat if they know. You can put in the chat to everyone, or just to me, if or just to the panelists if you don't want to put to everyone. But if you do know that, you can put it in the chat.
So I can also say for so because of insurance differences, I have had every CGM on the market.
Oh, wow.
Yes. So going from my mother's insurance to mine, to my last job, and then to my new job, I have had ever since Dexcom, Libre, and Medtronic. So I cannot speak to Medtronic because to be honest, I did not personally like it. I did not find it accurate. I didn't use it much. And I actually ended up throwing some out because I disliked them so much. After they were expired, unfortunately, otherwise I just would have donated them. But I will say that the 3 CGMs beside Medtronic, they can generate reports like this. So if it's for Dexcom, if the parents or the student is comfortable with it, they can actually share their data directly with you. And so you can see that data, or like this was pulled from my CGM website, and you can run from my CGM app, and you can run reports, whether it's a 30-day report, a 90-day report, but Libre can also do that, and so can Eversense. So those 3, they should be able to run reports for you, and you can see, average time in range, what the projected A1C would be, and if they're having major fluctuations. So if you're not comfortable with, like really talking them through major fluctuations, one thing you can do is, tell their parents that perhaps they should see a dietitian, to discuss fluctuations after meals. In my internship, I was actually at the diabetes center at Alfred I. DuPont. So, at least there used to be some great dietitians there, and that would be a great place where you could possibly help a student, is if they're having major fluctuations, encouraging them to seek help.
Okay. In the chat, some people said 4 of 4 have CGM, 2 have CGM, 4 of 4, 1, 2, and then Robin said not all of adolescent patients have type 1, therefore not all have the need. I wish more patients were eligible to use the CGM diagnostically. And then in the Q&A, Joan said, I always know if my students are on a CGM or Dexcom. In the 18 schools where I sub, most of the type 1 children are on CGM or Dexcom, but not all of the type 2s.
Yeah, and that's definitely something that's evolving, is the use of CGM in type 2 diabetics. Unfortunately, some providers don't think it's as necessary because they see less swings. I professionally disagree with that. I think it's good to be able to just see how meals and how carbs affect your blood sugars. When I was working in dialysis, I would encourage a lot of patients, especially my uncontrolled type 2s, and obviously these are adults, but I would encourage them to talk to their doctors about CGMs, because even in type 2s, it can be good to see what foods cause big spikes. For example, when I used to drink sugar-free coffee creamer, even though it was sugar-free, I would see huge spikes in my blood sugar. So I ended up switching to something called nut pods, which is 1 gram per 2 tablespoons. And ever since, my morning blood sugars are better. So having that CGM allowed me personally to see it. And while those swings may not be as big in type 2, it's important to be able to identify foods that are causing spikes for those patients. So personally, while it's not being used for as many type 2s, professionally, I think that it should be.
That's good insight. Nina, you have a question?
Well, for those folks out there that have students that are type 2s, I'm curious if they're in pediatric endocrinology specialty or if they're just followed by a pediatrician. The reason I asked that question is because everybody isn't totally up to speed on what insurances will cover. And I don't want to steal Tina's thunder. I don't know if she's going to get into this, but you know, the nice thing about commercial insurance is they don't have all the hoops you have to jump through like Medicare does to get a CGM. So if your student is waffling about, you know, I can't afford it, or they don't know if they can, it's a simple call to the insurance company, and not that you guys have to do that, but the family can make that inquiry. And if it's not a Dexcom or a CGM, a Libre works fine for kids with type 2. But again, I agree with Courtney. It's about these periods of time that they're out of range, and whether they are type 1 or type 2, they're still damaging those eyes, kidneys, and, you know, long-term complications. So I don't think there's any such thing as too much monitoring here. And God knows they hate that, you know, this is a lifesaver for what used to be only finger sticks, and that, you know, or die. So.
Well, and I needed to bounce off that. Honestly, I would say for the families, don't recommend that they call the insurance, because the insurance can be confusing. You can go onto Libre or Dexcom's websites, and you can request that they look into their insurance for you.
That's right. Yeah, absolutely right.
For you. And it makes it so much simpler.
They can be the messenger.
Yes. And they know what questions to ask. You know, being a dietitian and having a Master of Health Administration, I'm a little better at knowing what questions to ask. But for the average parent, you know, that can be complicated. And, you know, they may be told, oh, the co-pays, you know, for this much, and that's for a 30-day supply. And so sometimes when they get there to pick it up for their children, the 90-day supply is triple. And so they're getting a much higher copay. So, you know, I utilize that service. I utilized that service when I switched from Libre to Dexcom, because I had looked into Dexcom with my last company. My co-insurance for it was going to be $800 for 3 months. When I switched to Quality Insights, I reapplied with them. I just followed up with them and I said, hey, I have a new job. Can you run this insurance? And it's $30 for 3 months. So, you know, big difference there. And they did all of the work. They just called me and they were like, this is what they said.
Yeah, and sometimes it's a matter of whether it's covered under their major medical or their pharmacy. And I'm finding that more and more of these are covered under their major medical, and unfortunately they run it through pharmacy and it's denied, or they have these huge copays. If they simply flip it to their major medical side, it's nominal. So I agree with you, Courtney. That was a great idea. Thank you.
Definitely. And even also needed the opposite of what you said, because for me, the pharmacy is what makes it $30. My major medical would have been.
Wow. Yeah.
So, you know, and again, they can also explore both of those. So the parents would be calling 2 companies, and, you know, they're doing everything for you. All you did was give them your information.
Great.
So Robin asked in the chat, which department she has trouble just establishing if certain meters are covered. And it's a durable medical.
Okay, so they're typically durable medical equipment. It depends. So for example, I have Express Scripts. They cover it under a pharmacy benefit for my Dexcom. But if you go onto most of their websites, there's an application the parents can fill out, and they'll just ask for the insurance information, and they will run it both through durable medical equipment and through pharmacy and figure out which one has coverage, whether either has coverage and which one has better coverage.
Got it. Okay.
So again, kind of taking a lot off the parent.
Gotcha. So changing gears a little bit, we do have a question from Rabina. There was a mention last evening of a student that is struggling with his new diagnosis, and the idea of sharing with peers was a challenge. How did you feel about sharing your diagnosis with family and peers, and what would you suggest for that student?
So unfortunately, I feel like I'm probably not the best example, because my friends are mostly medical. They're nursing, they're dietitians. And so they were, you know, clinically they understood what was going on, and were very quick to jump in. Honestly, the first thing I would say is trying, whoever the practitioner was that had them as their student, trying to establish to that person that it's not anything they did, whether they're type 1 or type 2, it's not anything anything they did. They're children. They didn't earn this. There's nothing they personally did. But it is something that needs to be handled. And so trying to break down that stigma, like I addressed in the beginning, just letting the kid know that it's not as uncommon as they may think. And also that, that they're going to grow, they're going to understand. And I still have bad days. Everyone does. For my birthday last year, my girlfriend got me a stuffed pancreas. And she was like, I figured you could yell at it on bad days. And I do. I yell at the stuffed pancreas. And is that a healthy concept? I think so.
Yeah.
Just acknowledge. Yeah. Just acknowledging, that stigma, that burden that's there, and that stigma, like trying to make the student understand that it's not their fault. It's just something that unfortunately they were dealt. And also that, maybe letting one or two people in to begin with to be their support system, the people closest to them, because having a support system can make it a lot easier. My friends, were fantastic. I can't even explain how helpful they were to me. When I do injections, I started a new insulin pump, but when I do injections, I'll kind of, poke them, and they're so used to just grabbing my arm so I can do insulin in the back without hitting muscle. And they don't even think about it. They don't stop conversation. They just pinch. So again, unfortunately, having dietitians and nurses as friends, I feel like I'm not the best example, but I really think that the first thing is breaking down that stigma that patient's probably feeling.
Awesome. Thank you. And sorry for the dog barking. Okay, a question in the chat. How would you recommend for a school nurse to talk to students and parents who want their elementary child to eat whatever they want as long as the carbs are covered? She has a student who eats 2 snack bags of Takis and 2 Little Debbie treats from home for part of their lunch every day. The mother does not want him to have any restrictions with food intake.
So I would try explaining to them that while the importance of the coverage, to keep the blood sugar in a good range is important, because I would also explore the other implications that are going to come along with a diet such as weight gain. Weight loss is really complicated on insulin. Personally, I've put on 40 pounds since I started insulin. I used to weigh 115 pounds. It's very complicated to lose weight on insulin. And so I would just, try and stress the other health factors that go along with eating unhealthy things besides the effect on his diabetes. I mean, off the top of my head, I don't know the cholesterol of Little Debbie's, but that doesn't sound like a good thing. I don't know what Takis are, but
Yeah, I don't either.
The cholesterol, the sodium, and you're also setting a dietary habit that's going to more than likely continue into adulthood, and can cause other health issues. I would also stress that he's already at higher risk because of his diabetes for cardiovascular disease. So trying to, since she doesn't want to touch on the diabetes because she's saying it's covered, I would stress the other important nutrition factors such as cardiovascular disease, the potential for obesity, because there's a lot of other things that go along with that. It's not just diabetes. I don't believe in denying myself everything just because I'm diabetic. I love ice cream. But I also know that if I eat ice cream every day, even if I'm covering it and my blood sugars are good, I'm going to gain weight.
Right.
That's how that works. So I would, if the mom doesn't want to talk about that, I would try another topic such as the risk for cardiovascular disease and obesity.
Nina, you have a question? If you do, you're muted.
My lips are moving. No, I was thinking maybe there's some kind of negotiation that could happen in terms of how many times a week this event takes place. I mean, it sounds like it's a daily thing, which I agree with Courtney is problematic for weight gain. Is the child type 1 or type 2 though? That would be another, and not that matters, because clearly all the things that Courtney mentioned about, weight gain and high risk.
Type 1.
Okay. So they're clearly adjusting the insulin for the carbs, and, on the label, it says carbs, but then it also says sugars. And my rule of thumb for how many grams of sugar per serving is acceptable is something of nothing above 10. That's just Nina's rule. I mean, so there's probably other people out there that say less than that, but I would pretty much guess that a Little Debbie, one of them probably is, if it's 35 grams of carb, it's 35 grams of sugar. So there's a difference between covering for carbs and based on what we heard last night, and then there's, covering for sugar. So there, and clearly I either mom needs to sit down with a dietitian, and have some pretty intense understanding of what a nutrition label is for, so that maybe she can begin to rethink her, her. And I understand. I mean, she's clearly trying to not to add to his different, this whole mental health thing about being different, but at the same time, I bet the kids around him don't eat 3 Debbie's and Takis every day either, so
that was kind of what crossed my mind. I was like,
yeah, I mean, come on, seriously?
You still want to encourage healthy, like a healthy relationship with food.
Right.
One of my best friends owns a private practice where she specializes in eating disorders. And, you want to encourage a healthy relationship with food for everyone. Like, we don't want to encourage an unhealthy relationship where this kid feels like he can never have a Little Debbie, but also there's the opposite where, like, that's still an unhealthy relationship with food. You're overeating, and you're already, as I stated, you're already at a higher risk for so many other things. Another thing, gum disease, because he's eating all these sweets. There's a lot of added factors that I would bring up with the mother if she doesn't want to directly discuss, the carbs and this. She doesn't want to cause an unhealthy relationship for him with food, but you almost are by allowing it. You're enabling bad habits to form, and it's complicated. I was a ballerina growing up. Unfortunately, in ballet, eating disorders are encouraged. So, I grew up with a rather unhealthy relationship with food because of that. And it luckily led to my career. I fell in love with food. I ended up having a healthy relationship. I became a dietitian, but she's almost taking it to the complete opposite, where she's creating an unhealthy relationship with food, with unhealthy food, rather than encouraging a healthy relationship. Things are occasional. And as a dietitian, I never believed in no. Like, I don't want to ever tell someone, no, you can't eat that, because that's how you lose people. But, there needs to be a balance. There needs to be portions and occasional foods. And that's definitely, like, those foods are definitely something that should be occasional, whether the person's diabetic or not. So, trying to address other things of just general health, perhaps, that I've been discussing, rather than directly addressing his diabetes in relation to the Little Debbie's.
Yeah, and I always say there's no bad foods, just bad behaviors, and clearly there's nothing wrong with a Little Debbie. I'm curious to know what the kids around him say. I'm thinking about your friend, or in the restaurant, Courtney, the experience you had with the sweet tea or a sweet drink or whatever, and they said, oh, it's not going to kill you. I mean, they're setting him up for bullying somewhere in his life, where somebody figures out he has diabetes and they know he's not supposed to have all this stuff, and now they're beating up on him in the cafeteria because he's not, all this stuff is coming out of his his lunchbox, and he thinks, mom would never set me up to fail, so what's wrong, and I don't know, I just think there's a tremendous opportunity for bullying to develop there if it hasn't already.
So we have about 2 more minutes on this session, but Courtney, this is just my question, and we kind of touched on, we did touch on mental health last night too, and Dr. Nita's presentation. So from a personal, if you don't mind sharing, from a personal experience, you said you were 115 pounds and you gained 40 pounds on insulin. How does that affect your mental health?
It's hard. It's really hard. I was always very tiny. I hit 100 pounds in college. So going from turning 30, like you figure I've almost doubled my weight since my senior year of high school. In the meantime, I have had a fair amount of people tell me how much healthier I look. that like my prom dress was a 00. And so it's difficult sometimes to deal with, to acknowledge like, this is my body. And especially with COVID, there's, like everyone else, there's been weight gain. So, I'm trying to I was about to join a gym when I got bit by the dog. So I'm trying and hoping, I'm hoping in the next like 2 weeks, I can get back to a gym and not worry about the number, but about how I physically feel. And I know that BMI is used as a measure, but BMI was never meant to be an individual measure. It was meant to be a measure of population. And so I think the providers who look directly at that, my primary care doctor doesn't say anything about my weight because she knows what I do, but her intake people will. I've snapped at some of them for saying something. I tell them, like, that's not your place. Your place is to take the numbers. And while I acknowledge that was probably me, it's not their place. They're not, in the care like that. So just acknowledging that numbers only mean so much. But personally, I can say that, but then my mindset can be hard because I had never been overweight until I was overweight by BMI until I was diabetic. I was typically underweight.
Wow. Yeah. Well, thank you for
Well,
sharing.
I don't want to go back to that, but
Right.
yeah,
Right.
finding a balance.
Yeah. There's a healthy balance for sure. Awesome. Well, thank you so much, Courtney, for being here. And you ended early, but that's okay because that was really great Q&A session. And I think people enjoyed hearing the personal side of this because there is a face with this disease. So it's great to hear directly from you. Thank you so much.
Thank you.
All right. And so with that, we'll move on to our last session of this 2022 symposium. Christina Trout, after 40 years at BB Healthcare, she recently retired as the diabetes management inpatient provider. Providing diabetes education for outpatients, inpatients, and the community, Tina's passion is educating healthcare teams, students, families, and persons with diabetes within the state of Delaware. A longtime volunteer for the Delaware Diabetes Coalition and dedicated diabetes advocate, Tina was named the inaugural recipient of the Tina M. Trout Leadership Award. So with that, Tina, did you want me to pull up your slides, or do you want to share your screen?
I need you to pull up my slides, please.
All right. Pull them up here. Can you see those?
I can. Thank you.
All right. I will mute myself and turn off my camera.
And is my camera on?
Yes, your camera's on and we can hear you. So you just tell me when you're ready for me to move forward.
I want to say thank you for the second invitation. I was asked back because they wanted to know a little bit more about insulin pumps. So I do repeat some of the slides that I have from last year, but I hope I've added some things. I've been really impressed with all the speakers that we've had so far, and I hope I can provide some additional knowledge to what school nurses need. So thank you so much for taking the time to participate in this conference. So I'm going to talk about students who use insulin and insulin pump and glucose monitors. Can change the slide. Okay, I have no disclosures. So this is for the diabetes educators. Okay, so we're going to talk about insulin, pump basics, CGMs, or continuous glucose monitors. We're going to talk about what school personnel need to know when they assist students on insulin. And we're going to define what students should be doing, as well as parents and guardians. And Nina touched on the IEPs yesterday. There needs to be an IEP written, and we'll go over what the contents of that should be. So next slide. What I'd like to do is just kind of go over the different actions of insulin. We have four major different actions of insulin. I know this is something that we've gone over from nursing school for those of you that are nurses, but what I wanted to just kind of hone in on is when we look at rapid acting insulin, it is the most appropriate mimic of insulin that's released during a meal. So as Dr. Corcoran said yesterday, it's the rapid acting insulin that may be over insulinizing students and children. because what we do is we look at the food intake, whether it be Little Debbie's or Takis or whatever those things are. But the rapid-acting insulin is now being used in accordance with calculating carbohydrates. Why carbohydrates? Because they turn into 100% glucose. So the whole point of this is that we try to match the amount of glucose somebody is eating with the dose of insulin. Now, how perfect is that? It is not. It is not a perfect thing. People with type 1 diabetes have none. So it's kind of a guessing game. We as providers make recommendations, but as we have seen in all of the prior discussions, presentations, is emotions, stress, exercise, hormones will also play an effect in blood sugar control. So rapid-acting insulin is just one component. Whether it be given by a syringe, by a pen, or through a pump, we're still doing calculations, hopefully. We're playing a guessing game. But we know that that works very quickly. We say within 15 minutes. And it's all used up basically, or it works its best in that first hour. So that student has to be eating, whether they go to the cafeteria, whether they come to you in time, whether they forget and they come to you after. Even at home, we need to be matching that close to the mealtime. Now, short-acting insulin was first evolved in 1921. That was the regular insulin that they gave children with type 1 diabetes to survive, because all of the children with type 1 were dying because they made no insulin. So regular insulin has been along for a very long time. It is now man-made. We call it human insulin. But as you can see, there's a difference in the peaks here and the action time. So short-acting insulin begins in about 30 minutes. So it takes a little bit longer. Its peak is longer, and its duration can last over 6 hours. So the reason we don't use this very much anymore is it is not working along with carbohydrate breakdown, because it stays in the system longer and it has a higher increase of low blood sugar effect. So we still have it in the marketplace. In our hospitals, we use it for our IVs, very fast acting, but it doesn't last very long. It is the least expensive, one of the least expensive insulins. If we get it in a vial, we can get it from Walmart for $25, where we know the other insulins that are out in the marketplace are much more than that. So we don't see it used very often. The other one we don't see used very often is intermediate acting insulin. That's your NPH. That is the only cloudy insulin that has to be shaken or rolled before they can administer it. So the thing with when people were taking NPH, we always worried when we gave the first dose in the morning, oh my gosh, they have to hurry up and eat. But actually it takes 2 hours to get into the system. So it doesn't work immediately. And what happens is it has a peak every single time it's administered, which means a person gets more and more insulin over that 12-hour time frame that it lasts in the body. So again, I always am concerned when I see people taking that insulin, elderly people that might be taking it, some of ours that are taking a premix insulin, which is both short-acting and intermediate-acting insulin, that they know that they must eat a lunch if they're going to give it at breakfast. So a lot of people that eliminate meals, get really busy in the middle of the day, have a higher incidence of hypoglycemia. And again, that is why we don't often see the NPHs any longer. NPH usually is given 2 times a day, with breakfast and with dinner, or breakfast and bedtime. So it depends on what they're doing with the pre-meal, if we're just giving some rapid-acting insulin or some regular. So it depends on the provider and what they look at the patient's numbers and see. So long-acting insulin is what we call peakless. And I have some slides that are going to show you all the different names we have available for long-acting. Way I try to explain long-acting insulin is, let's say the provider says you need 24 hours or 24 units of Lantus. If we divide that by 24 hours in the day, what's happening is that person basically is absorbing 1 unit, 1 unit, 1 unit for 24 hours. They have added some amino acids and zinc to that insulin dose, so it when it's absorbed or when it's inserted, it takes about 1 to 2 hours to begin working. And in that time, it sits in a space and it will release micromolecules of insulin every so often for the longevity of the insulin. So it is very different than the NPH. It is called peakless because what we find with long-acting insulin is it really doesn't significantly cause the lows unless we find out that they're giving it and they're adjusting it themselves in the evening. So next slide, please. So in recognizing all the different insulins in the marketplace, I went over and looked, and this is something that I got from January 2020, or 22 rather. So we have a variety of rapid acting insulins in the marketplace. The first one I'll talk about is called Afrezza. That is the not injectable rapid acting insulin. It is an inhaled insulin. It is tablets that are crushed and they put it in their nose and they inhale it just immediately before each meal. So Courtney, I'm thinking of you and seeing that you're on 11 injections a day when you're not on a pump. That might be something you want to consider, is possibly using this just to eliminate some of the injections that you're taking. I haven't really worked other than one person that uses this, so I'm not an expert in this, but I know it takes about 12 minutes. What happens is when they inhale it, it goes deep into the lung tissue and it's absorbed rather quickly. It works rather quickly and it's only there for 2 hours. Now, the problem with Afrezza is because we're inhaling it, the person who takes it cannot have any respiratory disorders. Asthma is a respiratory disorder, so it's discouraged. And anybody with asthma, cigarette smokers, and COPDers. So in our elderly group, we have a huge amount of smokers and COPDs. So we don't usually see it in our hospital settings because not anybody is usually given that option. But in the kids, I was curious to know if you are seeing any children in your schools that might be using the Afrezza. And I would like to know if there is, if you can just share some of that with me. Now, Fiasp is one of the newest kids on the block. It's made by Novo. And this number for begins, that is incorrect. Fiasp starts within 2 minutes to 14 minutes is what it says. So it begins immediately. It doesn't waste any time to get in the system. So the 16 to 20 minutes for beginning is incorrect. It's usually 2 to 14 minutes. So it gets in the system rapidly. It has a long peak, and it says there is some controversy about how long it'll last. I've read 3 hours, I've read 6 hours, so it still lasts for a duration. They say it's more similar in action once it gets in the system like our regular insulin. So Fiasp, they're saying, is basically used for maybe people that are very forgetful, but they can give it after the meal because it works quickly into the system. If they're not sure what they're getting with pre-meal carbs, they might use it post-meal once they finally consumed everything. The other thing I want to say about Afrezza before I forget is what I keep reading about. It is a choice for many people who refuse to take injections. Whether that's correct or not, I'm reading that in the literature. I haven't seen that. So we now have Fiasp, very active. Novolog has been around for quite a while. It's also called Aspart. It works within 15 to 20 minutes, has an onset, let's say in the middle there, around 90 minutes, 60 to 90 minutes, and it can last a little while. So these have to be given quickly before somebody eats the meal. Now, Pedra has been around for quite a while also. It's glulazine. It's made by Sanofi, the same people that make Lantus. So sometimes when somebody's on Lantus, they will also be using this rapid-acting insulin. So I just want you to be familiar with some of the names that are out there that maybe you haven't seen before. But it's fairly similar. Our Humalog is out there. That's been Eli Lilly's thing. So all of these can come in vials and syringes. Vials and pens, excuse me. So Humalog is just a little bit longer than the Novolog. They say Novolog's faster than the Humalog, but it also works very rapidly. And then Admelog came out in the marketplace, and it is an analog that was made to be less expensive than the Humalog. So I don't know how many people are seeing just Lispro instead of Humalog, because that's now in the marketplace to be less expensive than Humalog, and Admelog is out there to be less expensive. Next slide. So when we look, and I didn't put anything in there about regular and NPH because we don't really see them in our students, but our Lantus is the first one. So glargine, as you can see, has many names. When we look at the first four, all of them are glargine with a different trade name. Does that make it confusing? Absolutely. So, you know, people, when they come in and they are on Toujeo and we put them on Lantus because that's our hospital formulary, they get very confused, but it is a glargine. So they work pretty similar. What I mentioned is all of these do not have a peak. So all of them will last up to 24 hours, if not longer. There's only one called Levemir or Detamir, made by Novo, and it lasts maybe 12 hours. So this is the one that usually may need to be given twice a day because it doesn't last long. And then we have Traceba. That's the newest long-acting insulin in the marketplace. It comes in two formulations, U100 and U200. So U100 is for anybody. We're seeing given a lot to our younger type 1s and our older type 1s. It comes into the system about an hour. It doesn't have a peak, but they say it is about 12 hours that it is working a little faster, but it has a 42-hour duration. So this one lasts a lot longer. This may be a better choice for somebody who may be forgetful taking their long-acting insulin because it's in the system a little longer. So this and the Toujeo you see come in different concentrations. So U200 and U300 are higher concentrations than the U100. That means that there's less insulin when they give the dose. They could be the same dose, 10 units. But in this, the U200 and U300, we're looking at the real estate on the body. How much insulin are they injecting into the site? So if they're taking very large doses, we might, in our adults or our type 2s, we might see the Toujeo or the Traceba U200 being used because of the amount of insulin that gets into the site. So it's a little more concentrated, even if the dose is the same. It's a little more concentrated. It takes less space in the tissue. So where I got this from was Children with Diabetes, and that was from January 2022. And then I also got this from our diabetes education site. So just so you know, there's lots and lots of things out there. Now, Semglee, I didn't even mention, but that is has come out the latest. It is similar. It is a glargine, but it is less expensive. So they say, I haven't done cost analysis. So Semglee and Basaglar were put out there to be less expensive than the Toujeo and the Lantus and the Traceba. So I'm not sure about cost, but we see insurance companies basically dictating what kind of insulin people will need. I do want to ask Sarah, if she's still there, to just make a comment about Dr. Lenhart and what we found out about insulin, that there was a shortage of insulin in the pharmacies.
Yes. That was back in probably December, November, December. It was a supply chain issue. And yes, there was a shortage and the pharmacists weren't able to fill prescriptions. And so we worked with our legislature and both at the state and federal level, and actually did get some direct response. And I haven't heard from him since that they're still having this issue, but it's obviously life-threatening when they need it to survive and they can't get it from their pharmacist.
They can't get it. So there was a big concern, and I thank Sarah for bringing it up and working with the legislature, because there were concerns back then that patients weren't able to get their insulin. I don't know if the school nurses saw that or not, but thank you. Okay, so I just wanted to take a little time to discuss these things, even before we start talking about pumps, because we do have type 1s and type 2s in the school system. And type 2s may be put on some oral agents, but at some point they may require some long-acting insulin. So a lot of times we'll see a long-acting insulin like Lantus or Basaglar or Traceba being given in the evenings, and oral agents like metformin during the day to break down that resistance at the site. Okay, next slide. Okay, so now we'll just have a little bit of conversation here about it. What is an insulin pump? And I'm going to elaborate on this a little bit. We've seen these slides before. The first picture there is a patch pump. This one has no tubes at all. It is called an Omnipod. It's pretty cool because it's just attached to the skin. The thing that's in the student's hand, let's say, is called a management system, an iPod, and they basically are receiving basal insulin through the pump continuously for 24 hours, but to give their boluses, they require to have that iPad to enter their carbohydrate amounts, their blood sugar amounts, and then activate it when they decide on the dosage. And then the dose is given through that iPad, okay, or through that patch. So the next one is, we're just looking at the tubed insulin. So all the other insulin pumps out in the marketplace do have tubes, which means inside of that little box that we see attached to the pants of or the jeans is where the insulin is in a reservoir. So a reservoir looks like a syringe. They fill it like a syringe, other than your T-Slim, which has a cartridge itself that needs to be filled, but the Medtronics look like a syringe. It's attached to tubing like IVs. We attach it to the tubing, and then it's connected to the site, which is on the body. So there's different types of sites, attachments there that go into the skin. And so we talked yesterday a little bit about sports, and I did want to share with you, I thank Sarah again, I got to look up the name of the institution, but it's the Delaware Interscholastic Athletic Association. I spoke to their coordinator, Stephanie Mark, and there is a statement in their records that says that for contact sports, they're not to be wearing their pumps. It doesn't mean their site has to come off. What she said is they're allowed to use their pumps during downtime, that they can go have a bolus if they needed to. And we didn't say anything about continuous glucose monitors, but what it does say, and she was supposed to send it to me, email it to me before the end of her day, which I have not received. So when I do get it, I will send it to Sarah if anybody's interested in seeing that. If they detach it from at the site, that tubing away from the site, and they remove the pump right there by itself, they do say it has to be padded well. So all of the insulin pump companies, I will share with you, do have all kinds of attachments. I'm sure they deal with this. There's so many people that do sports that they have attachments that can go over the skin site so that it will not budge the inserter. But all of those tubed pumps can become detached. So I would think that the same thing could go over their continuous glucose monitors, that they just put something over. Sometimes we put a larger type of dressing over that, or some foam, and then tegaderm it over it, that they can still pull it up and access it if they needed to during break times. So I just wanted to share that with you. So what you see is that anything but the patch pump, you do see screens, and on the screens, it does tell you what's going on. Okay, Skin Grip is a great example. Yes, I've worked with Skin Grip before. They also have different companies, and I think Skin Grip comes from a different company. And that's, if you go to the Diabetes Forecast magazine, every year they have a resource in January, and you can see all the different devices and equipment that's available for somebody that has a pump or anything to do with diabetes. And that's where I found about the Skin Grip. It covers the whole thing, and it really protects the site. So that's a great resource. So thank you, Courtney. Next slide. Okay, so now we're going to talk about differences. Basal insulin is just like your long-acting insulin, if we can consider it that way. It is what the provider programs. And if you look at this little slide to the left, at the bottom, it says basal rate in blue. And so that is, as I mentioned before, if we were using 24 units of Lantus, that person would be getting 1 unit, 1 unit, 1 unit, 1 unit. But a lot of people have, we see patterns where they have blood sugars that are higher or lower. So in this case, this person's blood sugar must be lower during the time they're sleeping, and that's not an unusual thing. We see a lot of times the blood sugars go down during the night. So they'll require less insulin, or more insulin, I guess, more insulin there for the dawn phenomena or whatever they're experiencing. So they may have one basal rate, or they may have multiples. Okay, so it's just delivered internally. So the only thing that we use for basal insulin in a pump, or what's used for basal insulin in the pump, is the rapid acting insulins. So there is no more Lantus, Levomir, Traceba, or whatever they might be using long acting. Those things go away. And they only use the Novolog, Humalog, and Apidra. Those are the 3 that are approved FDA for pumps. So those things are going in. So as I mentioned before, looking at that prior picture, if anything happens to that site where it's infusing in the body, what will happen is it will not provide the insulin that person needs. So if they have some problems with the site, either by the cannula that's underneath what we see, or the tubing, if the tubing might have air in it, or air pockets, I call them bubbles, they are not getting a continuous delivery of insulin, and that's where we may see higher numbers. Next slide. So our bolus insulin is completely different. Bolus insulin is the same. It's still using that rapid acting insulin, except that each of the pumps can deliver amounts that are set by the physician or the provider or the whoever is taking care of them. And so there are calculations, or they are programmed to have calculations that cover carbohydrates. So it would be in there that 1 unit of that type of insulin they're using for every so many carbs. Okay. They also have what's called sensitivity or correction. There is a program set for 1 unit of rapid acting insulin will change their blood sugar so many points. Okay, so when we look at basal and bolus insulin, when we look at the total daily dose of somebody is using for insulin, both the long acting insulin and the short acting insulin, or the rapid acting insulin, we put those together, we kind of divide that total in half and divide that half for what they should get as a basal rate. The other half then is allowed to be delivered by bolus. Okay. Now I will tell you, working in my role, outpatient and inpatient, I find that high A1Cs may be due to students or patients not delivering that bolus dose. As Courtney said, taking it for every meal and for snacks, that's a lot of injections if they're doing injections. That's a lot of looking at what they're eating, concentrating on what they're eating, entering that into their pump, because that's really the only thing they have to enter now. The correction is the blood glucose meters, the continuous glucose meters kind of send radio frequency, their blood sugars directly into the pump, and it does that calculation. So the only thing that people that wear pumps or that have type 1 diabetes have to do is look at their carbohydrate amounts. Okay, and they need to enter that into the pump, or they need to work with their little calculator or whatever to determine how much rapid acting insulin to give with meals. So if they're not doing that, if they're lazy, they don't want to take it, or they're just overwhelmed or overburdened or burnt out, as we heard a statement yesterday, we might not be seeing those bolus doses being given. And I always say that's 50% of what you get in a day. That could be where you're losing or where you're gaining higher blood sugar numbers. Okay. So if they don't deliver those basal rates or basal doses, they can't reduce their post-meal glucose values, because that basal rate is only going to go in as much as the provider has set for them. A half a unit, a third of a unit, a whole unit, 5 units, whatever it may be. That's all they're receiving. They're not getting anything else for their food or their correction. Next slide. Okay, So how does it infuse? When we look at that, we have our patch pump on the left at the top. That is attached to the skin. So all that person does is they take a syringe that comes with the pod and they fill it. It can only fill with 200 units total. They may not need all that, but they fill that syringe. They enter the needle of the syringe into the other side of the patch. It is a rubber piece and they insert it. So the insulin is inside of that patch. What they do then is they take the paper off of the back of the patch, and on that tape, it adheres to the skin. That little iPod that she's holding in her hand, when they push the button's going to activate the insulin to, not the insulin, but the cannula to enter the skin. So they don't even have to insert anything into the skin. The patch does it for them. So it's a wonderful little device. I see it used in a variety of different people. Other than that, we have devices that typically have a needle inside of a cannula. So in that second picture at the top, what we have is it's showing you the needle on one side, and the other side is where we have the cannula. So it's inserted with a device into the body. The needle comes out, the cannula stays, and it is attached to the skin with tape. Okay, so the bottom one, it shows you that tubing can be detached from the site. And so it's looking at the tubing on the left bottom, and then the right bottom is they can detach it. They do not have to take it completely off. Okay, so that's how it infuses. Next slide. Where is it worn? Well, it needs to go in the subcutaneous fat, so that needle or the cannula needs to be in the subcutaneous fat. It can be worn any place that we have sites for injecting insulin. So we see it on the back of the arm, the abdomen, the outer thighs, the upper buttock, and the gluteals. Now, a lot of people that have been taking insulin for many, many years, and I have people that I've met that have had diabetes from 18 months, and now they're 25 when I see them in our hospital setting. And they have lots of those lumps that Dr. Sammy talked about last night. They get hypertrophy or lipodystrophy. It's a fatty globule that's in there. I just call it scar tissue. That scar tissue gets hard and it's indurated a lot of times. It doesn't hurt if they put a needle in there. So a lot of times they just keep using that site because they don't want it to hurt. So if they're giving multiple injections a day, they might use that same site for the two different kinds of insulin that they're using. They may use their pump and keep putting it in the same place. I can't tell you, I have gotten, when I'm working inpatient, I always make them show me where they're injecting, and I can't tell you the number of lymphomas that I see, not lymphoma, but lipodystrophies that I see. We actually had a gentleman who came in our hospital that came in with severe hypoglycemia. And what we found out is he was, I don't know how old, he was elderly, 80 years old possibly. His family was staying with him and he was using insulin, and they decided to inject his insulin for him because he was providing his own self-care. So he went so low. They told us it was the same dose that the gentleman had been giving. When I lifted up his shirt right there on the right side of his navel, he had this lump that was so high, it looked like a cup was underneath it. And it was hard as a rock. And so there was orders in his chart to go have all kinds of x-rays. They didn't know what this thing was. And so when I talked to the gentleman, like anybody else should have talked to them, and I said, why, do you have any idea why you have this? And he looked at me and said, that's where I've been giving my insulin. And I said, how long have you been on insulin? He said, 20 years. And every single shot had gone into that lump and had created that problem. So we do encourage rotating sites for that reason. If you look at the little squares, the way I teach people is if we look at the belly, start on one side, work all the way across, and then come down and go back again, then come under the belly button and go across and come back again. Then we're looking, if we just use the belly, it's saying 3 weeks, 4 weeks without putting it in the same site, even though it's in the abdomen. Same thing with thighs, same thing with the back of the arms. And a lot of my young students or young patients that I've had like to put it, guys like to put it right above their belt line or right below their belt line in their buttock area. And they have very good, they like the patches back there. The patch pumps, but they put it in a lot of different places. I've never seen too many in the buttock. The only time we've seen that is with some of our dialysis patients that really have no sites left in their arms and their abdomen, and they may use it a little lower than the love handles at the top. Next slide. Okay, so what do pumps do? Pumps will provide bells and whistles to alert them when something is wrong. So if the cartridge is empty, it'll tell them that, but usually there is an alert for when it gets down to a certain level. Let's say they didn't listen to the alert, they ignored it. And when it completely is out of insulin, you'll hear alarms and bells going off until they do something about it. The other thing that I do want to mention is if it is completely obstructed. So if the cannula below the skin is typically kinked, we cannot see it. If it's not completely kinked, they will continue to get insulin in a smaller volume. So these people, we may be seeing very high blood sugar numbers, and not when we look at the site looks good. We don't see any leaking insulin. The site is not hard, but what may have happened is it's kinked underneath. Now, we will not get an alarm unless it's completely obstructed. That's the only alarm we're going to get, completely obstructed. So a lot of times when we see them going in the high 300s, we teach them to bolus if we don't see the blood sugar come down. Then we do encourage taking a bolus of insulin if it's 250 or 300 with a syringe so you can actually, with their pen to actually see it go into the body. Then remove their site, change their site, and move it to a different place. So those are things we do. When we can look at the pump and we can see how many alarms, they have histories, we can look at how many alarms they've gotten. The other thing the pumps do in the gold, they can calculate bolus dosages, which is awesome because they don't have to carry a calculator around with them anymore. The pump will do it for them. They have the CGMs that may be putting that information in, and it'll tell them how much insulin they might require. So that's the correction. And the boluses for the carbohydrates, that's really the carbohydrates are the only thing a person wearing a pump has to enter into the pump. So some pumps, but mostly all the pumps now will communicate with a blood glucose meter or a CGM device. The other thing that they do that when a person is giving injections, and let's say they continue to see their blood sugar go up, we know with insulin action that rapid acting insulin that gets in their system may last 3 to 4 hours. If they're checking their CGM or doing frequent blood sugars and they're seeing it 200, 240, 200, 210, maybe going to 300, they might be giving themselves an additional injection to help to bring it down. So what a pump can do is if you've given a bolus, and we have this set into the pump that you can get another bolus with a full dose of insulin, 3-4 hours. Some people only require 2, some people require 6 if they got gastroparesis. Active insulin tells us how much insulin is still on board. You still have some insulin infusing according to the time from when you gave your last dose. So what it will do is when it does the calculation, it'll suggest a lesser dose of insulin. So we don't stack it. That's what we call it. And stacking will cause hypoglycemia. Okay. The other thing that pumps are great about, and we heard Dr. Corcoran mention this when he talked about removing the pump or putting in temporary basal. All of the pumps we can look at if they're going to do exercise, if they're going whatever it may be, so that they don't get hypoglycemic right away. There is a way that they can go into the pump, and let's say that basal rate is at 1 unit per hour, and they know for the next 5 hours they're going to be doing sports. He said that they might want to bring it down to 50% or less. They can reduce that rate. So instead of getting 1 unit every hour, they might get a half a unit or less than a half a unit for that number of hours. And then it automatically will go back to what it needs to be given in what has been programmed. Next slide. Okay, so insulin pump options. So I have on here the 3 different manufacturers that have pumps. And so it's a small device, we know that. I'm hoping you can see what we've got here. I'm going to make my slide bigger. But on the left, we have the first pump is a Tandem T Slim 2, and it's the automatic control. And so what this pump does, I'm first going to go to the basal IQ. So what this pump does, it has a colorful screen that you'll see, and you'll see a graph that's across the bottom of that. And what this pump does is it will shut off automatically when a blood sugar hits the target that's set in there. So we usually say 60 to 80 for our kids. Most people don't want to wait to 60. I usually say 75, but again, people don't want to be aggravated by bells and whistles. So it depends on the students. So that's one of the things I tell staff nurses to recognize is when is it going to alarm for a low. So you have an idea. If it's at 80, we have some time to get them the treatment, especially if we see the arrow going down. So the other one is not a basal IQ, but it's called, I did write that down and I'm just forgetting right now. So the other one that we have is the T-Sim Control IQ. And this is the advanced pump that can adjust, automatically adjust and do a correction bolus if needed. It also can provide the information about a low blood sugar. So both of these pumps do work with iPhones. They can get all that information about their blood sugar on iPhones. The iPhones, because they all are wearing CGM devices, that CGM can be sent to a number of different iPhones. So this is why, we'll talk about that in a minute. The middle one, the Omnipod Dash, is made by Insulet. This is the newest, brand new one that's out there. So we still have a very small pod or patch that is on the skin, okay? And they have a very big screen. Their iPad screen is very large, and they can see everything they need to see without having to go through all the different mechanisms to see the different things. So they can see what their basal rate is now. They can see the last time they gave a bolus, how much time is the insulin still infusing. They can see what their blood sugar is. So this is a really visual, nice visual device. I've seen several people using it and they really, really like it. It does not yet, it can be sent to iPhone so other people can see it. It can go from 0 to 0.5 unit increments. So it does not give insulin possibly for an hour or two if somebody's requiring like maybe 8 units of insulin in 24 hours. So if they don't need it, it may turn it off for a little while. It's cleared for all ages. So it's got its own, it can be plugged in to the wall. So we can view it from other iPhones, and it is waterproof. They can go, both the Tandem T-Slim and the iPods can get wet. They can't go very far down, but it can get wet for a period of time. So again, we talk about going into the ocean, into the pools, not taking their $5,000, $8,000 pump with them, but maybe disconnecting it from the site, except for the iPods. Okay, the Omnipod Dash, this is one that we would put a device like the Safe Skin over it to protect it from the water, even though they can go down 35 feet. So your Medtronic doesn't use names, they use numbers. So we have a Medtronic 630G. That's been out on the market for quite a while. What you see on the face of this is they have their continuous glucose monitor showing the blood sugar values in that centerpiece. They also have what their blood sugar is. They can see on their scale how much insulin they have in the reservoir, how their battery is, and it can function by just touching those buttons at the bottom. So that is showing you a Guardian. It works with the Guardian device. The other one, the Medtronic, okay, so the 630 has the ability to stop when the blood sugar's below 70 to 100, whatever, or 70 to 90, whatever they want to set in their pump. So it'll turn it off when it gets there or before that so that they can treat it. And it stays off, and then when it gets back up to the number that is allowable, then it will go back to what the basal rate is. Now the Medtronic 770G can do two things. It can turn it off, and it also can go into automatic mode. What that means is they can put it in automatic mode, and this is the most wonderful thing. It's kind of like a fake pancreas. In the mode that is automatic, it will adjust their basal rates automatically. So they don't really have to give corrections. It's doing it every hour. Okay, so every hour it can change what they're getting through their basal. It's pretty remarkable. It also has some settings in there. Both of these Medtronic pumps have some settings in there that they can, if they eat the same thing all the time, they can automatically put in their insulin to carb ratios. If they eat the same thing, they can mark it in there and just touch that they're eating this certain breakfast or the certain lunch or the certain dinner, the certain snack, and they just have to touch it and it will automatically give them the dose that is set in there. They don't have to do any calculations. So they're getting much better with technology. Medtronic says they're coming out with a newer, greater one. It's going to be called a 780, and it's supposed to come out in October of 2022. So these are the devices we have. So what we know is the pump, when we talked about insulin, we can give 1 or 2 units with a pen or a syringe. The preciseness of a pump is it can give 0 to 20 units at a time, right? So when they set their basal rate, it can be 0.005 units. So for our little ones that don't require much insulin in a 24-hour time, the pumps are really pretty remarkable. Now I went into their sites and I was looking at, because of what Dr. Sweeney said last night about what it can do. And I looked at one where it was a mother who was talking about the wonderful place of she had an 18-month-old, and they put him on a pump, and they had it in a backpack, not a backpack, but a fanny pack that was turned around that he couldn't touch, where they kept the pump, but they did. So they have a guard on that where the child can't change anything, it's child-proof, and they would make all the corrections and do all the calculations. So pretty cool technology that's out there, but it does give very precise doses. So we can either give 1 or 2, or some of the syringes out there now go in half units, and some of the different pens do go in half units. But other than that, we can't give 1/4 of a unit. We can't give less than 1/4 of a unit, but a pump can. So let's say if they were taking 1 for every 10 grams of carb and they ate 52 carbs, with a pen or a syringe, we would give 50 grams every 10, they would get 5. With a pump, it would actually be a 5.2 units. So it would be much more precise than what we can give with the other devices. Okay, next. Okay, so when a student or when a child is using an insulin pump, or anybody, checking blood sugar frequently. Now we heard that from Dr. Swamy last night that can cause a lot of trauma. Even when we were doing finger sticks, it caused a lot of trauma. I would hear young adults coming to me and saying, I don't put my numbers in there because I know I'm going to have an argument with my parent. If it goes to 300, I'll just fake the number. I'll fudge the number. I won't put it in. But all of the monitors that are out there, all of the devices have memories. We can actually go back and see them. If their parents don't do that and they take whatever they're writing or whatever they're telling them, that's great. So a lot of times they won't do the blood sugars because they know they're too high, or it's just a bother. Now with the continuous glucose monitors, Courtney says she doesn't like them because of the bells and whistles. I've heard that before, but it is the best thing that we could use for people to know what's going on every hour if that's when they check. CGMs can be showing us blood sugars every 5 minutes. They have to know, they have to be old enough. So our little ones probably cannot be making the decisions. They may still need to be coming to the nurse's office. I'm not sure how all this works in your office, but telling them the school menus are available online. The parents can look at what they're getting. If they don't like what's on there, they could pack, but they need to know how many carbs, so that if a child who's young is wearing a pump, they might require the help in calculating how much insulin they would need for the carbs. Depending on their age, they have to understand the effect of food and physical activity. If they eat all those Little Debbies, we're going to see a blood sugar rise. We may not match it correctly with what we gave for the bolus dose. Same thing with physical activity. We move around, we work out, after school or for a planned activity. A lot of times we have to know what that's going to do to our blood sugar. So counting carbohydrates, knowing about exercise are two key important things. And then symptoms. They have to be able to tell you, and I always recommend that families let you know what the typical symptoms are that student experiences. I've had people tell me they blurry vision, they'll get a numb lip. There's all kinds of things other than the shakes, the sweats, all kinds of things that we hear in the textbooks, the black and white stuff. Same thing with high blood sugars. People get them confused. You need to know. We need to know how to monitor the pump and where the insertion site is. So they should be able to show you those things, where their pump is, where it is held on their body, on their clothing, and where it's inserted on their body. Next slide. Okay, pump limitations. It is user dependent. So it relies on humans to make the judgment calls. Okay, so the user or whoever is assisting is a human, and humans make mistakes. So I'm glad that the two presenters on psych things talked about feeling very guilty, because family and the patient, who are the diabetic, feels very guilty if they make a mistake or if they're not doing something right. So it does rely on the input of a human. Now, override the pump. What that means is, let's say we were going to go out, and after school somebody said, let's go play tennis. And so if they put in their carbs and they look at what their blood sugar is, and it may be 200, pump may give them a calculation for the 200, it may give them a calculation for the carbs, but let's say they know that somebody invited them to play tennis afterwards, and they know they don't need as much. Now, Dr. Corcoran talked about over-insulinization, and that happens a lot if we don't understand what activity does and what food does. So they can override the pump. So if it says they need 2.2 units and they know they're going to play tennis, they may activate it to give less than that. They still have, or the person that's running that pump still has the ability to make a change. They don't have to go exactly with what the pump says. If they are unable to use the pump, they have to know about using insulin with a syringe or with a pen device. And with a pump, the limitations are, the unable to know if insulin is given by a syringe. So if they are having very high blood sugars and we change their site and the insulin was given by syringe, the pump won't know that. So when you go to give another bolus through the pump, it won't know active insulin if you use something else to insert that insulin. And the pumps do not tell you about ketone levels. So they have to do something else to test their ketones. Next slide. Many advantages to using a pump. It's the most physiological method of insulin delivery. Pens, syringes, and pumps. So we have those options. It is more predictable because we're only using the very rapid-acting insulin. We don't have the long-acting in our body that stays there for many hours. We use the rapid-acting insulin because it's only a short amount of time. Now, the pump only uses that rapid-acting insulin. So disadvantages is the next slide, please. Okay, it has to be worn 24 hours a day. It doesn't give them a break. It works 7 days a week, 24 hours. Okay, if they take it off, they can't take it off for longer than an hour. Okay, so if they want to take a shower, they want to swim or whatever, it comes off for a very short period of time. It takes time and work. Absolutely. It is not the panacea. I have people that we talk about going from multiple injections to using a pump, and they think it's going to be the perfect thing for them because it's going to do all the work for them. That is a myth. Okay. It can still cause problems if there's kinks, if they're not getting delivery, if it's in a fatty tissue, that they still can develop diabetic ketoacidosis. Hypoglycemia will still occur with a pump. Weight gain Any kind of insulin will cause weight gain, but if they're getting basal insulin that they're not in control of, the pump is delivering it 24 hours a day. And that's the other reason I love a pump, is they don't have to rely on remembering to take an injection. It will work for however long it's on the body. We usually say no longer than 72 hours, but at least we know they're getting 72 hours of insulin for 24 hours. So it will cause some weight gain in those people who are not taking insulin regularly. And we all know about insurances, the cost of copays. It is a real challenge. So let's move on. So now we're going to talk about the continuous glucose monitors, the acronym of CGM. It's a very small sensor that's placed on the skin. And what it does is it measures interstitial glucose levels. So when we look at that first picture to the right, when that catheter is inserted under the skin, what it does is it's not in the bloodstream, but what it does is it's taking the blood sugar that's traveling from the bloodstream into the cell. So it's in the interstitial fluid. So sometimes that number may be not completely correct if they, like when they do a serum glucose. A serum glucose is blood sugar. Here it's interstitial fluid. So there may be some differences, but we call it real time. It's what's happening right now. CGM will provide a number every 5 minutes. So this is where they talk about playing that number game. Every 5 minutes, they are going to get a number. The CGMs can provide anything from 200 readings in a 24-hour, and I just saw on that 77, the Guardian can provide 280 readings in a 24-hour period. It is a great tool to assist with highs and lows, especially the lows. That's the most critical thing. We want to prevent the lows. And it does assist in A1C reduction. I have people coming to me after they've started using a CGM, a Freestyle, and they are absolutely thrilled that they got their A1C down from 9 to a 7. They've never been able to do that before, but it provides them with accurate information all the time if they want to know it. Next slide. Okay, so the CGM has three parts rather. There's a sensor, and that's the part that stays on the body for 10 to 14 days. Your Dexcom and your Guardian will continuous glucose monitors stay in for 10 days. The Freestyle can stay in as long as 12 days. So then there is a transmitter that is attached to a sensor and transmit the glucose data continuously, and a receiver. So that sensor, I don't have the picture here, but the sensor for the Freestyle is the size, it's the diameter of a quarter, and it is very small diameter. So it looks like a quarter size. It's very thin, and it's just a small circle that has tape around it. So it's basically worn in the back of the arms, okay? So it's inconspicuous most of the time unless they're wearing short sleeve shirts or sleeveless shirts. The transmitter is what's sending the information to the receiver. So the receiver will provide a visual display either on the receiver for the instrument itself, or it can be sent to iPhones, Apple phones, all kinds of things. So it's interstitial glucose. So that's the fluid surrounding the cell versus serum that's found in the blood vessels and capillaries. It does provide alarms. And there are arrows that are typically on it. The arrow up one time shows it'll give you a little bit of warning that it's going up slowly or going down slowly. Or if it's 2 hours, it's going up rapidly or going down rapidly. So looking at the alarm on the display can show you how quickly somebody needs to react. Next slide. So as I mentioned, hypoglycemia is the most acute risk that people can pass out from. They can have seizures from it. So I'm going to tell you this from an experience that I had with somebody coming into our hospital wearing a pump and a continuous glucose meter. Always make sure they have an audible alarm for that, especially when they're going to bed. If we have somebody with hypoglycemia unawareness, and now I see this in our adult people, they get no adrenergic warning signs of a low. They have no clue until they pass out. So we usually set those audible alarms from 75 to 80 for their safety. Now, school kids or little kids, the 80 may be too high. They may not want it any higher than the 70. Okay, as long as they get the alarm and they know they have to react. Now, this young lady that I will tell you about was wearing it, and I was the only one to be able to tell how long she had been hypoglycemic. She was wearing her CGM, and so I went through the memory, and I saw that she was below 50 when I looked at her graph. She was below 50 for 5 hours. She was below 50 for 5 hours. I didn't expect that she was going to wake up or that she was going to have some mental delays. What I found out is it wasn't set in audible. It was set in vibrate. So when she had gone low and fallen off of her bed, her mother never heard the alarm and she was in the next room. She found her when she wasn't getting up in time for breakfast. So she found her on the floor, unconscious, completely soaked, that they had to call 911. As I mentioned, the interstitial value may be a little bit off. I always tell them to wear it when they're in hospital. We do allow them to wear it in our hospital. I love it when they come in with it because I want to make sure the accuracy of it. Our hospital, we still have to do plasma glucose testing, even though they're wearing a CGM, but I want them to wear that CGM for their safety, that they know what's going on. So there's several devices that can be used as a receiver. As I mentioned, iPhones, iPads, iPods, Apple Watches. Now, some of them say they can go up to 5 to 12 devices. I don't know if we want 12 people watching what's going on, but I'm tickled to hear what I learned last year, that in the nurse's office, they had some iPads that were able to download the students' devices so they could actually see them. And I think that's a wonderful thing. But I'll just tell you this other thing that happened to me working in the hospital. I came in one day to see a patient that had a Freestyle Libre. And as I was walking down the hall, the nurse that was taking care of him said, "You want to hear what happened last night?" I said, "What happened?" I said, "I saw that she had low." And what happened? And they said, "Well, we got a phone call from her husband. And the husband said, 'Has anybody gone to see my wife? I'm seeing that she's at 50. Can somebody go in and check her blood sugar?'" They went in the room. She was not responsive. They couldn't get her awake, but our device said it was 52, which was low, too low. So thank goodness somebody else was watching her. That gave us that message, because we would never have known unless we had checked the blood sugar and it was a routine blood sugar check, or unless the patient called us to say they were feeling low. So continuous glucose monitors are wonderful high technology. They have to be used appropriately and they have to be used religiously. Now, I will also tell you that I truly recommend them. I have two, I call them adolescents because they act younger than adolescents, but I have a 22-year-old and a 25-year-old that has come into our hospital. They're frequent flyers in DKA. Now, because of the DKA, because of their hypoglycemia, they were not using a CGM. I got them a Freestyle from their physician to be ordered. We showed them how to use it in the hospital. So the next admission, they both came in with it. The third admission, one was not wearing it. The other one told me that they ran out of sensors. So the one that was not wearing it, I said, "Why did you not use your glucose meter?" "Well, I didn't really want to prick my finger. Okay, I didn't want to use it because I was kind of sick and I couldn't get up and I couldn't put it on." Well, you know, we learned yesterday we don't yell at people, and I had to bite my tongue rather, because I said to her, "You know, you could have not caused this DKA problem." All right, she actually had, both of them have problems with gastroparesis. So the issue is they're not liking to use their rapid acting insulin with meals because they're not sure they're going to vomit up right after they take the insulin, and they're not eating very much. So taking their insulin is a real challenge. We're trying to get them on pumps. One's dragging her heels. She has not done much about the pump. But The other one, when he told me he was losing his sensors, not able to keep the sensors on, we looked at the tape that could attach it better. But when his mom went to the pharmacy, they could not give him any more sensors because the time limit it wasn't 30 days. I will tell you, I know somebody mentioned contacting the company. Always contact the company. The company that either the Dexcom or the Freestyle, if you call their 1-800 phone line, they are going to send you an overnight express sensor. They do not want you to go without. You will not get it from pharmacy because they have to rely on the prescription frequency. So a pharmacy is not going to be able to do it any sooner because the insurance will not cover it. But you get in contact with the company where your CGM comes from, and they'll send you a new sensor. Okay, so I'm just giving you that as some things that we have found out in our hospital setting with the people that are wearing them. And I've had to do it a couple of times when they've had to go for MRIs, they have to come off. When they come back to the floor and they're going for surgery, they may want to take it off when they go to surgery, but we need to get another sensor on when they come back. So I'm continually calling the companies. They've been great to me. They've been great. I make the patients call them so they know how to call them, but I do tell them to put that number into their cell phone as a contact. Next slide. Next slide. Okay, so here we have our 3 sensors. So you can now see that this Freestyle Libre, this little disc at the bottom is the size of a quarter. It's worn on the back of the arms. This one is different. It's not a continuous glucose monitor, but it does provide you with glucose results every 5 minutes, but you must scan over that disc. It doesn't make a difference if you're wearing clothing or not. You just scan over where the site is and it will come right up on the screen. So what you see here is it can go backwards to show you where the blood sugar's been, but you can see a big blood sugar number there, and this one has an arrow going up. And as you can see on the screen, you can see where it is going up, but it's not in the danger zone. It's not over their graft amounts. Now it shows you the Dexcom. It is an iPod that they have that they can carry. That's their not their sensor, but their receiver. It also has iPhones. They can go on different iPads or iPhones. So a Dexcom is a continuous glucose monitor. So it will continuously give you blood sugar values every 5 minutes. You can see where you are. You can do it every 5 minutes with a Freestyle Libre. The reason I got the Freestyle Libre for these 2 individuals in the hospital, 25-year-olds, because I wanted them with their gastroparesis to see when would be a better time to give their insulin. Because we had such a problem with them using their rapid-acting insulin with food, or when they should give it with the gastroparesis, do we do it before you eat or after you eat? I encourage them to do a blood sugar before they eat, an hour after, 2 hours after, 3 hours after, for a while when they ate certain foods. So it would give us a better idea. Do we give the insulin before, after a meal? It would give us some guidance, but there were some issues with getting that data. So a Dexcom or a Guardian would have been a much better choice. The Guardian comes with the Medtronic pumps. A Dexcom, anybody can get without a pump. So anybody can wear a Dexcom, anybody can wear a Freestyle Libre, typically only if they have type 1. Type 2, you have to finagle it a lot. If they're Medicare, they might have a better advantage. Some of the younger ones, unless they are on insulin, multiple injections, there is a toss-up whether or not they can get it. But these are the different devices we have. So the little inserts are the tiny little things you see at the bottom next to the pumps. Thank you. Go up. So hyperglycemia. Now let's just flip over and we'll talk about high sugars. When they're students, okay, how do we know they're having high sugars? Well, they might not be able to concentrate in class. They may be falling asleep when they have high sugars. They may be asking to go to the bathroom frequently in every class, maybe twice in the same class. They're bringing lots of water with them. They may ask to go out to the water fountain. So these are typical signs of high sugar. Now, as the prior person who spoke before me discussed, is stress. If they're taking exams, if they're having a hard time in class, if they're ill, they've got a cold, or if, like she had, an injury, a bite, they injured themselves out on the field when they were having gym, any kind of pain or any kind of infection, sore throat, all of those things can also bring our blood sugar up. So it's not just one thing. We can't always say it's food. We can't always say they're not taking insulin. There are too many variables that can cause highs and lows. It's not just one thing. But these are typical signs of when they have hypoglycemia in the school. Next slide. Very high blood sugars. So if they're wearing a pump, we don't like very high blood sugars because we can correct them. When they do their IEPs or whatever, they need parents or providers, if you don't have good parent communication, needs to give you a blood sugar number of, if their blood sugar is not coming down, what do you do next? Or if it begins to climb higher. So there are rules. We teach anybody that wears a pump, 240 is our cutoff number where they have to bolus to see if they can bring the blood sugar down. Because the rapid acting insulins work within the hour, we should see that number coming down within an hour, 2 hours. We tell them to drink a large glass or 2 glasses of water, 2 bottles of water. If they cannot get it down, it keeps going up, then there's something wrong at the site, whether we see it or not. So a lot of times they have to give insulin injected with a syringe or a pen to make sure they're receiving that insulin. I did mention that before. We need to make sure the insulin is being delivered to lower that sugar. Ketones, parents may be providing you with some ketone strips. If they have very high sugars and they have ketones, we may be going into DKA, or like somebody else said, if they're not eating, they may be showing ketones, but they typically would not have a low sugar. So these things need to be written down as a backup plan. So if you have parents that are not good communicators, don't have a lot of interaction with their students don't seem to know, you may need to get a physician prescription for what should occur, and the parent should be signing off with you. Next slide. So common pump malfunctions: loose connection of the tubing, dislodging or movement of the cannula may have come out of the skin, it may have kinked, air bubbles in the tubing. I see that a lot in anybody that's wearing a pump. If they have some visual disturbance, which they may when they have high sugars, a lot of times they're not seeing the air pockets when they set up their reservoirs. Ineffective infusion site, we keep talking about the scarring at the skin, it's poorly absorbed, or they have an empty insulin reservoir, or they might need a new battery. Now the reservoir and the battery, the pump will tell you, unless it's completely off, and it won't tell you anything. Next slide, please. Okay, so hypoglycemia. Now we're all aware of these symptoms, the mild symptoms. Typically mild symptoms, typically you get mild symptoms when they're jittery, shaky, sweaty, change in personality and behavior, headache, lightheaded. When they start to become confused and uncoordinated when they're getting out of their seat to walk out of the room, that's when we need to start getting very concerned that they probably need help from somebody else. So these things, we can see them. We might see them looking jittery. Their hands are shaking. You can see the sweat beating up on their forehead, their neck. These things you might want to say to them. Do you have anything that you can take right now? Some juice, or have some candy, or some tablets that you might want to take right now? You might be low. You might want to check your numbers to see if you're low. But again, they don't want to interrupt class. They don't want to tell anybody. So we have to rely on other people. Now, if it's severe, they're not going to be able to respond. They will become unconscious. They may have convulsions and jerky movements, like seizures. Next slide. So again, I keep repeating, hypoglycemia is dangerous. It's very serious. So again, so many variables can cause it. Too much insulin, too little food, too much activity. If they become symptomatic with the shakes and the things, there's no meter, no CGM available, always treat it. Never question it. Okay. If they look like they're having a low, treat them if they're having a low. You're not going to give them a whole box of cereal or a whole gallon of juice. You're going to give them a juice box. It's not going to run that sugar up extremely high. So I always say, if I always talk to parents, I talk to the person who I'm speaking to, how do you know when you're having a low? Does your body talk to you, or do you just see it on the machine? You know, they should always have in their backpack on their person, we heard this yesterday, about 15 to 30 grams of rapid acting carbs. I talk about juice boxes all the time. The sports people always have sports drinks. They have Gatorades, things like that. Glucose tablets and gels come in all flavors. They come as gummies. They come as liquid. A container of milk will work. It is a carbohydrate. Hard candies, jelly beans, gumdrops, even honey works. So sometimes I tell them just to keep a little honey jar or those little honey bears at their bedside and just stick it in their mouth and squeeze. Those are things that are quick. And never leave a student alone. So if somebody's saying we're sending a student down because they have low sugar, they're coming to the nursing station, are they having somebody bring them? Because we've heard the horror stories where students can fall apart going down a stairway, and then nobody finds them for a long time. So always have them have a companion, and always have some fast-acting carb. Thank you. Next slide. So we do have glucagon. They mentioned yesterday, glucagon is not something they always want to carry, but it is a product that is made to be available when somebody's unresponsive or needs help from somebody else. Now, glucagon, when I was in nursing school and up to last year, we had to have a syringe with fluid and a little bottle with powder. You had to put the syringe into the powder, shake, shake, shake to make it clear, pull the powder into the syringe, and then inject it. Any place you give a sub-Q injection, it can also go IM. So there's two new formulations. The glucagon that we knew when we grew up had a 1-year shelf life, so it constantly needed to be replaced. They're expensive. Again, you have to make sure that the insurance company will cover for it every year. Now, the new formulations have a 2-year shelf life, which is nicer. So anytime they give glucagon, what has to happen is they need to be, especially if they're unconscious, turn to their side so they don't aspirate. And, you know, wherever they are on the field or in the school, to call the 911 number. Next slide. So the first picture I have is the newest and greatest is the Baqsimi. Baqsimi, that's what it's called, Baqsimi. It's a dry nasal powder. It's in fast-acting form. It can be given as a single dose and used for one time. So the nasal inhaler is inside this yellow package. Typically, when they are given it as a prescription, there's 2 containers that they get. It is puffed into the nose, so you can just push it and it goes directly into the nose. It doesn't matter if they have a cold or if they actually inhale it, they suck it in, it's still going to work. Whether it's just a drop in the nose or whatever, you don't have to suck it in. But even if they have a cold, it's going to get back there. It's indicated for severe low blood sugar where they need help from somebody else, and it is FDA approved for children 4 years of age and older. Okay, the second slide, please, or the next slide. Gvoke is still a pen, okay? The difference is there's no needle, you don't have to titrate it. What you require is inside the pen. So it comes in 2 different doses, half a milligram or a full milligram. There is a dial where you dial it in. When you put it on, you just push it onto the skin. There is no needle that anybody sees, which is wonderful. So you just put it in the site that you want to inject it, press it down. It does deliver it, and it sucks that needle right back up when it's done. So it can be given anywhere, okay? So usually they get 2 Gvoke pens in a prescription. So those are the things that are options now. I don't know if you've seen them in the nursing stations. I don't know if parents give them to you. I don't know if a student travels with it in their backpack. I don't know how this works, but just know there's other things available. Next slide. So what should you know about an insulin pump as a provider in the school system? What kind of pump they have, where the pump is, if they have a CGM, and look at their skin sites. I can't tell you how important that is. Do they know what their blood sugar value is? How do you know how to suspend or disconnect the tubing if they have a very low blood sugar. So the pod or the patch pump, you're going to have to use that little iPod and suspend the insulin, but the rest you can just disconnect if they have tubing right from the site. How to inject with a syringe if they have a high glucose, if they need to use ketones. If you take everything off, is there a storage place? Does the parent have to come to the nurse's station? Do they have to go to the office to get their supplies? Next. Okay, so these are the kind of things that we talk about. Type of insulin, basal rate. So a basal rate is that 24-hour, how much insulin they get. Do they need to tell you about their insulin carb ratio so you know how to do calculations? What do we want their blood sugar target range to be? And now this is the new terminology. The pumps, the CGMs can tell you target in range. So usually 80 to 180, 70 to 180 are typical target ranges where we want that blood sugar to be anytime during the day. And a plan for problems. And the manufacturer's 1-800 numbers. If you need assistance with anything, you can call the pump providers and they can talk you through problems that you might have. Now, when I did talk to, or what the Dr. Swami said, I guess, is if you're not getting this from the parent, you may also get it from the provider. And what she also did say is what they told me at the contact that I made for school sports is if there is a medical need written by a physician that they must keep their pump on their body, it must be written and it has to be discussed with the coaches. So those are something that we put it in a safe place in their wherever, under their wherever that has to be discussed. Okay, next slide. Parents should be giving you, if they're wearing a pump, infusion set in case we need to change anything, reservoirs, any kind of skin preps, batteries, syringes or pens, ketone strips, and glucose meter strips. If they bring their own meter or if you have your own meter, I'm not sure how all that works, but that's conversation between you and the parents or their guardians. Next slide. So what have you learned? What can affect blood sugar levels? Insulin, food, physical activity, illness and stress, and it's all the above. There's too many variables. We can't say one thing is going to change your blood sugar. It's a multitude of things. So sometimes we don't know what caused the problem. Next slide. And insulin pumps can calculate insulin boluses based on carbohydrate intake and blood glucose levels when they're entered into the device. I hope you know that that is a true statement. It is human error. So those things have to be put in there so the pump can calculate it. Next slide. Okay, so insulin pump information. Every pump has a website. They have virtual videos there. You can interact with the pumps on the sites. They do have pump manuals or calling the 1-800 number. Next slide. And this is where you can get more information. I'm sorry that bottom doesn't show you the last thing on it. Thank you, insulinpumpers.com. Okay, so we have the American Diabetes Association. The program where I took this from was the diabetes.org Safe at School. And about in the middle, it was designed in 2016. The guide came out, all of the information is still correct. It still had the old glucagon in there. But other than that, it had a lot of excellent information. Those you can get sent to your schools. And then, like I mentioned, diabetes forecast. Every January, it comes out with a diabetes resource guide. It has every newest option available for people. So you can actually, I didn't put the website there, but it's diabetesforecast.com. That you can get in and just go to the January issue. The other things, I found Children with Diabetes was a wonderful site. That's where I got some of that information about the newest insulins out there. College Diabetes Network. I found that to be a very informative site. There are books that students can get, parents can get, and what to expect from their healthcare team when they go to college. I thought it was awesome. Diatribe has so many resources. They have a ton of websites to connect the student or to connect with Facebook or any other kind of computer site. And then insulinpumpers.com have all the insulin pumps that you can review and compare. So I thank you all for the next slide, for inviting me. I hope I did provide you with some information, and I'll be glad to take any questions.
Awesome. Thank you so much, Tina. I don't see any questions in the Q&A, but we'll give people a few seconds, minutes here to type some in if they have any.
I know I
thank
talked
you
fast.
so much.
So.
Thank you. It was very informative.
Thanks.
I did see, oh, Nina has a question. Go for it. You're muted, Nina.
I just want to remind the audience that the DTMP, the diabetic treatment plan that is supposed to be done annually with the providers, whether they're pediatric endocrinologists, pediatricians, whoever, that should include all of this information that Tina's addressed tonight. And you know what, if it's not written down, you can't do it. So, I mean, I know that's the nursing law. You can't do anything that isn't in print. So if the I'm saying it wrong, but if that management plan is incomplete and doesn't address what you guys need, or what you've learned that you need, then it needs to go back to the parents who need to take it back to the provider. So that's your license that you're, testing there, right, Tina?
Yes. Yes, and that's exactly what Dr. Swarmy said yesterday. She writes them all the time. Written prescriptions have to be done.
There's templates for that stuff. So this isn't rocket science. I mean, you can actually go on the ADA website and pull it off and send it home. Yes. I always like to say, if you have the resources to do it, to send these ahead of time in the fall to the families, if they're coming through your doors, because you all share across the school districts. They move from grade school to middle school to high school. You all know who they are by the time they get there. Those documents should be just automatic, and it wouldn't be a bad idea to, like I said, put them in the mail, send them out, get those current updated documents and back to you, very first part of school year.
Yeah, and that website that I gave you, the diabetes.org, about the schools, children at school, it has all of those in print that you can print out and give to the parents or the students to take home.
Awesome. Well, thank you so much. We did not, no other questions came through. So just a reminder to everybody, when you X out of this Zoom, hopefully you'll get a link to fill out the survey. You do have to fill out the survey again tonight. It's pretty much the same thing, except it will ask about these speakers instead of last night's speakers. If you don't get the link, let me know and I will send it to you. And with that, thank you again for joining us, and we'll hopefully do this again next year.
Good night, everyone. Thanks for joining us, and thank you again to the planning committee. Good job.
Thanks. Good night.
Thank you so much, Sarah. I appreciate all your help.
You're welcome.